Today, we're going to go over polypharmacy and deprescribing, which I think is something that is very timely actually in this time of COVID that's hitting our facilities so hard because anything we can do to maybe decrease med passes, get rid of some essential meds is only going to help the people that are working in those facilities. And so we'll look at a couple different items that probably are a review for everybody, but maybe some kind of look at some tools or other tips that maybe we haven't thought about as much to try to decrease medications. And so what we want to do is take that bowl on the left and move it closer to something on the right. Try and get rid of some medications, and we'll kind of go through the reasons for some of those different things. And so we know what an adverse drug event is, and we're trying to prevent that. Adverse drug reactions many times, can be that allergic, or not necessarily the allergic reaction, the IgG mediated side effects and hypersensitivity, but happens when the drug doesn't work how was it intended. And maybe we need to alter the dosage regimen, or maybe we cause side effects because of that withdrawal. Adverse effects, we definitely want to make sure, and as we go through some of the tips, sometimes it's just making sure our EHRs have all the data. Even if it wasn't a true allergy, we'll want to know that a certain drug maybe caused a certain, side effect that was bad enough that we wouldn't want that medication put on again, and leads to safer prescribing down the road. Many times in the people that we follow over the years, we'll have a medication get started, and if it's not on that list of ADRs, a year or two later, it many times gets added back. Other things to look at, adverse drug withdrawal events. And so this is a set of symptoms that are related to the removal of a medication. So that's why we always want to think about those medications that make it through the blood-brain barrier, that we usually need to taper them off and usually not stop them kind of cold turkey. Inappropriate medication, use of medication whose potential risk outweigh the benefits. So those are drugs that we usually don't want to add, and we'll look at some tools there. Therapeutic failure, here's where the drugs don't work like they were intended. So the best examples here are when we think of like CHF, and so maybe we started the right drug, we started an ACE inhibitor or a beta blocker, but we didn't titrate it up to actually get to the place where it would have therapeutic effect. And the studies don't show that maybe it doesn't work at that lower dose. Another example might be the acetylcholinesterase inhibitors like donepezil, the other medications in that class. Many in that class, the very first starting doses are more of the titration doses, just to make sure that you tolerate it, and we need to make sure that we keep going up on those medications. And then we have polypharmacy, and so if we look at polypharmacy, it's using multiple drugs together. When it comes to a number, the literature really doesn't agree on the exact number of what is truly polypharmacy. Most definitions talk about 5 or more medications per day. Definitions can range anywhere from 2 to 11 or more. And I've also seen definitions that say if you're on one medication, but it's not indicated, could be considered a polypharmacy. And so I think where we want to get to is probably where this slide is, that we don't really care necessarily about the number of medications we're on. We're making sure that the medications we're on are all indicated and beneficial. Get away from maybe meds we should have never added in the first place. That we try not to have our geriatric people, especially if they have financial concerns and those type of things, add on over-the-counter things or supplements that might interact with other things. We want to stay away from things that are no longer necessary. And the classic example I always like to use is iron. Many times after surgery and stuff, we need some extra iron, but we maybe don't need it 3 years later when we're having issues with constipation, our hemoglobin's back at 14 type of thing. Polypharmacy, just some other kind of stats, that are elderly. are at risk for having medications, and the stats kind of show that people over 75 are on multiple medications. If we're in long-term care, that's a major risk factor for having lots of medications. It's easier to add than subtract many times. Having increased medication tends to increase the number of unnecessary meds. And so some things that we'll talk about later are things that we can do to try and reduce unnecessary meds, are having pharmacists or physician providers making sure to focus in on those medications and look at what we can possibly look at deprescribing, or maybe we can add things that can maybe treat two conditions at once. Other things that can be done is we can look at maybe disease states that are getting utilized inappropriately, and then doing a focused detailing on that specific disease states, whether it be diabetes, dementia, etc. Maybe behavior management in dementia. Maybe it's feedback reporting, so looking at the different antibiotics that people are using and looking back to see if they were appropriate. There's a lot of consequences with polypharmacy. One of the main ones is that eventually, if people have financial concerns, maybe sometimes they don't take all the medications, and maybe they're taking the vitamins that their person at the salon told them that they should take, or they just decide to take the ones that are once a day, and those type of things. So it can lead to non-adherence and failures that way. Unnecessary medications, ADRs, and kind of the prescribing cascade. So like the classic example that I like to use with prescribing cascade is we use that NSAID for pain, and all of a sudden we have edema. Well, instead of maybe getting rid of the NSAID, we add a diuretic, and then that diuretic leads to potassium being low. And then the potassium's hard in the stomach, and we add a PPI. Well, now the pharmacy's trying to tell us the PPIs long-term will cause osteoporosis, so we're doing vitamin D, and it just keeps going on and on. And so age, like we talked to, increases polypharmacy risk. The more conditions, and obviously the longer we live, and medications are part of that reason why we live longer and those type of things. But as we get more diseases, the tendency to add more medications. Over-the-counter and supplement use. We haven't found that fountain of youth, but all these internet ads and all these different ads try to get us to take all these different supplements and try to live forever. And then, like I said, long-term care can be a contributor. And so in 2019, the Loan Institute, which was founded in 1973, is kind of a think tank to try and kind of come up with some really good ideas as far as healthcare is concerned. And one of the areas they looked at was medication overload in the United States. And so sometimes knowing the contributing factors can help us kind of reduce polypharmacy. And so one thing to think about is that many times prescribing is kind. We want to help our patients. We have that empathy. And so we tend to want to give them medications. Also, many times, as providers, the survey is people rate us better if we gave them something. If we didn't give them anything, they're like, well, why did I go for that provider visit? Prescribing is a quick fix. None of us like to exercise if we don't have to. Do all kind of the non-pharmacy things. So sometimes prescribing can be a quicker thing. We're booked up. We don't have any appointments. We're not going to be able to get back and check on them in a week. All those different things can happen. Direct-to-consumer advertising kind of sets up and primes people for prescriptions. Being at home more, I've noticed on the TV, I almost think that I have rheumatoid arthritis and want to take one of the medications, because every 10 minutes it seems like there's a new rheumatoid arthritis or psoriatic arthritis kind of commercial. Guidelines, many of the guidelines that we follow very well, whether it be diabetes, CHF, and those type of things, not all of them are great at taking everything into account. As far as here we have a 90-year-old person with 10 different disease states. Sometimes some of those guidelines don't take all of that into consideration. or the studies really don't focus on those groups of people. Industry influencers, there are not a whole lot of places funding stopping medications. I don't think Dr. Gurvich was sending me too many $1,000s today, I don't think. Lack of teamwork sometimes that I always think about too. You know, when I first started with Todd, you know, we still had a lot of people really following their primary care doctor all the time. Well, it seems more and more that when we get sick, we go to the walk-in clinic, to the emergency room, then we see a hospitalist who can change during the time when we're in the hospital. We have our specialists. You know, hopefully we get to and have a primary care doctor. And sometimes our patients think that all of those people are talking, and sometimes they are, and there's other times where they're maybe not talking as well, and we don't want to get rid of medications that somebody else started. Care transitions is a huge thing in our elderly people. When you look at some studies in transition care, there's usually at least 3 medications changes every time we go from a hospital to long-term care. And usually at least one of those changes, we have no record of why it got changed. And so what happens a lot of times in our nursing homes is then the nurses ask for those medications back, and we find out later, oh yeah, that was what led to the hospitalization, and now we added it back and we're having problems again. Our EHR design, that can obviously be trouble, and if those things aren't updated, that leads to sometimes medications getting added back later. Lack of awareness, not thinking about how adding more meds could potentially cause more problems. Many times we only have a set amount of time to visit with these people, and so, you know, do we really have time to kind of go through their list of 20 medications besides go through all the problems that they're presenting with today? Come back very often for appointments. And sometimes we're not sure what things we should taper off or just stop or hold or those type of things. So we don't want to cause harm. And so here again, just some more reasons why we want to stay away from that prescribing cascade and adding medications. Also, I think it's kind of interesting that, and probably should just intuitively know this, but once we get to 20 medications, there's 100% chance that there's medications that interact. And what does that exactly mean? Also, when you look at some of the dangers, increasing falls and fractures, and I think you've talked about that at echoes before, but especially when we think about anything that can cause orthostasis, you know, our blood pressure medications, trazodone, quetiapine, all those things adding. Think about opioids, you think about diabetes medications and the risk of hypoglycemia. More stats kind of on polypharmacy and really showing that adverse drug reactions are a big problem. Each time we add medications, especially when we have people that are on those huge lists, it increases their chance of an adverse drug reaction. Also, an interesting thing is older patients taking greater than 6 medications in the hospital are 2 times as likely to experience delirium as those taking less medications, and more issues with impaired cognition. So again, in our elderly, many of them are very frail, and they're on that edge of having issues with dementia if they don't have it already. And then if we add more anticholinergic meds, and there's many that have just a low level, as we add those, we can put somebody into a delirium and increase their issues with confusion, which can also increase risk of falls. I like this older study that's from a couple of large long-term care facilities in North Carolina, but it showed that for every $1 we spend on nursing home patients for medications, we spend $1.33 in taking care of the adverse drug reactions those medications cause. So the NSAIDs, you know, all the money we're spending on those, eventually we pay for GI bleeds, you know, and that sort of thing. You know, the most current stats kind of show for elderly people outside nursing home, it's closer to $1 that we spend for each $1 on those medications. We spend another $1 on adverse drug reactions. And so what are some of the interventions and tools that we can use? Obviously, me being a pharmacist, I'm a little biased and think we should utilize medication therapy management, use pharmacists that kind of specialize in kind of deprescribing and appropriate use of medications to kind of go through the medication lists and kind of tee up for you what things we could possibly get rid of or taper off and those type of things. Making sure we do good med rec, comparing what they're supposed to be ordered and what they're actually taking. You know, we ask our elderly people, you ask them 4 times, and then finally maybe ask a specific question about pain, and it's like, oh yeah, I've got that bottle in the cupboard type of thing. So we need good med rec to know what people are for sure taking. Match those medications with the conditions and goals. Carefully consider medications to discontinue or substitute, all of those things. And so if we don't know where to start and where should we go, some things that are good tools, the first thing would be to look at drug burden indexes. And so whether you look up to date or you look at a lot of different literature, there's different articles that have placed a point rating system on different anticholinergic medications. And we're all aware of amitriptyline and diphenhydramine and those type of things, but we kind of forget about if we have people that are on mirtazapine, risperidone, quetiapine, trazodone, maybe a list of those medications, and even some of the less anticholinergic antihistamines, even loratadine and things. If we're on enough of those, it might just be enough to push our elderly person into having issues with confusion, delirium, and those type of things. Beers criteria. Dr. Mark Beers, back in 1991, he was a Harvard physician, that he recognized that when he used certain medications, they seemed to cause a lot of adverse effects. And so him with a group of other experts kind of put the first Beers list together. And then over time, American Geriatric Society has taken over the Beers criteria. And the last update was in 2019. And within that article, which is something to definitely have downloaded, there's lots of these different charts that kind of explain why certain medications are on the Beers list. And we need to maybe recognize what things are on the Beers list, but then we need to be able to then figure out what are we going to do instead. What I get mad at our PharmD students is they'll say, oh, we can't use that drug, it's a Beers list drug, or the doctor can't use it. And it's like, no, they can use it. It's just, have we tried other things? And are we monitoring for those potential side effects? So again, these lists are not supposed to be never prescribed. It's just to kind of remind us, you know, is there a better options? Or if we do use them, that we maybe monitor a little bit closer. Next to the stop and the start criteria, these were actually developed in Europe. And they were last updated in 2015, and these medication and these lists are very comprehensive and are a really good review. So for the stop, it really makes you think about when do you stop medications, you know, if they're not indicated, and it has all these different scenarios based on disease state of when you should stop medications. It also, the start criteria also looks at when should we start medications. If we need that NSAID and we have an elderly person, and especially if they have a risk of peptic ulcer disease, we better add some GI protection. You know, we might have to consider a PPI in those type of people. And so again, we try not to add medications, but sometimes we need it and we're preventing future harm. We have the FIT for the aged, or FORTA, which is also a European tool, and I haven't used this as much, but this actually looks at specific drugs and gives them letter grades from A, meaning that they're fairly safe and effective in the elderly, and moves down through D to medications that have a lot of side effects or probably not a lot of evidence of good use or efficacy in the elderly. Also, there's different algorithms or mnemonics like the MASTER that kind of just gives you good ideas on what to do to make sure that we get off our medications and use them appropriately. You know, that we start low and go slow, we titrate, and we review that medication list regularly. Another tool to consider is the Medication Appropriateness Index. And this one probably takes a little bit too long for provider visits, but when you do have maybe more time in a geriatric setting, or this is a lot of times what I use at the end of medication therapy management, is when you go through all their medications, you kind of then review with that patient, okay, we went through all your medications and we have an indication for all these except for one. And it kind of shows the patient and the caregivers that you kind of have went through everything in a detailed way. Here's just a slide that shows that 2018 article about what medications we should really worry about. You know, if we're not sure where to start, if we have people on blood thinners, diabetes medications, especially ones that can cause hypoglycemia, or if we're on a combination of oral kind of diabetes medications, or if we're on opioids, those are people that we should take some extra time to review their medications and assess what maybe we could titrate down. And so, you know, we always have heard the start low and go slow, but kind of more and more we're looking at for geriatric prescribing of trying to stop most and reduce the dose of a lot of others. And we're avoiding that, adding a medication, finding a drug interaction, those type of things. One kind of like story I like to tell too is that, you know, at some of our PNT meetings that myself and Todd Johnson, who's on this call, they'll sometimes go, why do you guys always find these crazy side effects and those type of things? And kind of, you know, we brush it off, but eventually we kind of said, you know, it's because maybe we're looking for them, you know, and until we know that certain medications cause that side effect, many times it just gets brushed under the rug and those type of things. And so, you know, whenever there's a new condition kind of happen out, we should, as pharmacists, and we should always think, is there a medication that caused this? You know, social workers need to blame the family. You know, the providers got to look at everything. But for pharmacists, we want to have that narrow focus and see if there's a medication that's causing a problem before we add more medications. And so some common ones we think about that can cause problems, as we definitely think about NSAIDs. I'm kind of interested to see, you know, as we try and use opioids less and less, you know, we don't have as good options sometimes in the elderly for pain. And we don't want to see a return of the days when we used NSAIDs all the time, which led to edema, worsening CHF, GI bleed, and those type of things. Some other ones to kind of always think about is with gout, especially thiazide diuretics can increase our uric acid levels and cause or worsen gout. Dementia, for sure. Anything that's anticholinergic, we want to see if we can reduce it, only have it for as short a time as possible so that we don't end up with more problems. Same with benzodiazepines. We want to try and get those tapered off. Parkinsonism. I don't think there's many months that go by that we don't see a case of where someone and the nurse sends the fax where they say, you know, we got this person with tremor, can we add this medication? And you look back and see that it was antipsychotic, you know, a risperidone or haloperidol was added, and it's like, no, we don't have Parkinson's, we have, you know, antipsychotic induced Parkinson issues, and so maybe we can just change up the medications rather than add another medication. Urinary retention. Anytime we see urinary retention, make sure we don't have any of those anticholinergic drugs, or see if we can taper back off on them. And so here's some of those manifestations in our elderly people that if we see these things, we should be reviewing our med lists. And if we're not maybe the experts at medication, or maybe we're not experts at psych medication or certain classes, that we get in someone who is, or get in a clinical pharmacist, consultant pharmacist, to kind of review what things might be causing some of these issues or adding to them. And so in reducing polypharmacy, the more information that we have, the better. It just makes sense. It makes us feel a little bit, gives us a little more security on, yes, we can safely taper off this drug because we know what the indication of why it was started. The more communication we have between our providers and whoever else in that person's team, that we have shared decision making with the patients and the families. So maybe we find out that the family doesn't really want to spend $200 more a month on a certain medication, or they're not that interested in prolonging somebody's life that's maybe getting closer to hospice or comfort care or those type of things, that they don't want to add potential side effects. So we really think about what the goals are for a disease state, but also what are the goals of the patients and the family. We consider those non-pharmacy approaches. Avoid prescribing prior to diagnosis. My best example here is again, many times nurses at assisted living, long-term care, they have a lot of good intentions in mind, but a lot of times they kind of force the facts that kind of say, yes, we want this drug, before really looking at what are the reasons that we're having these symptoms. We shouldn't prescribe the med before we decide exactly what is the problem. Whenever possible, and this isn't always possible, but if we can start one thing at a time in the elderly, it's a lot easier to kind of assess this drug actually worked or it didn't, or we actually had side effects, or we tolerated just fine. Make sure we reach those therapeutic doses, so we're not just adding on more and more medications that could add side effects. Let's make sure that we start low like we're supposed to, but then we make sure that we get them up to a dose that would or could be effective, and go from there. Avoid prescribing whenever possible. If all of a sudden we're seeing that side effect, could we stop that drug and try something different so we don't keep adding on medications? If we can add a mirtazapine for sleep, appetite, and depression, maybe we add that instead of each medication for each condition. Or maybe we use duloxetine or Cymbalta for somebody with chronic pain, try and get off those opioids, and also help people with antidepressant issues. Think about the drug and drug disease interactions. Think about if kidney function is changing. The simplest regimen, especially for, like we said, and maybe the times of COVID when we're having to use PPE, the nurses and those people passing medications, maybe we try and really consolidate and get away from TID med passes to more of a twice a day type of thing if possible. Avoiding duplication within the classes. We shouldn't be using 2 NSAIDs, 2 beta blockers, etc. And so there's my references. And so then we should see where we go. Are we doing the post test right away, or are we going to take some questions?
Yeah, why don't we, and 2 things. One, we had a case report. Did you want to do that? If that's available, and then we can do the post-test questions.
Yeah, let's do that case first. And maybe as I'm pulling up that case, Doc, maybe we could start with some of the questions, and then people could work on this case a little bit.
Yeah, that'd be good. Does anybody have any questions up until this point? Yeah, so one question I have, Mark, is the issue of quantifying efficacy of certain medications with what I consider high risk for side effects. And one of my favorites is gabapentin. And I'm just wondering if you have any methodology for analyzing its effect, because people typically just keep escalating the dose to the maximum dose. And it's not always clear to me that it's doing anything, for instance, for the neuropathy pain. So how do you approach that?
I think that's a great question, and it's my feelings the same way with gabapentin, is that with that medication so often you end up in the elderly a lot of edema, a lot of sedation. You wonder if that's adding to the falls and those type of things. So I don't know if there's any great methods other than really watching, are we able to decrease maybe our opioids, and using that as kind of a marker of whether the medication is effective or not. Are people reporting less pain, having less behaviors? So I guess I'd look at more of probably just the kind of clinical indicators and those type of things, and really then make sure that, are we not having sedation side effects? That's a perfect example, though.
Yeah, I agree. My favorite clinical encounter or question is, I go over the medication list and I said, how's this medication doing for you? And if I get like, I don't know, the question marks and, whatever start going up as to whether it's really being effective or not. Here's kind of an out in left field question. I don't know if you have any thoughts about it whatsoever, but, it's become somewhat fashionable for this intermittent fasting diet. And I'm wondering if you have any knowledge or information about how intermittent fasting, or even just fasting, might affect medication distribution or impact or side effects.
Yeah, it's kind of a really tough question, right? I mean, we don't know. We don't have studies. And so I'm wondering if there's anybody on the call that have noticed more of this, or also if they've seen problems or issues come up.
Yeah, well, so I'll just add that I had a patient with memory disorder and minimum cognitive impairment, and the individual was very much into, reading things about how to prevent Alzheimer's disease, and one of them was this intermittent fasting. Her provider had put her on both Namenda and Aricept, both which can have side effects, particularly decreased appetite and weight loss. And so she went on to this intermittent fasting with these two medications and wound up losing excessive weight and wound up in the emergency room with dehydration on top of that. So it just kind of was a case in point, not a lot of them, but like I say, there is increasingly more interest in this, dietary restriction, and for either for weight loss or for its overall health benefits. And I haven't seen a whole lot in the medical literature that really talks about, whether that increases the risk of adverse events or not with medications. I mean, I presume things like diuretics might increase the risk of hypotension and so forth, because
diabetes.
Yeah, exactly. So, well, it's just food for thought, I suspect. Do you want to launch into this case here? So it looks kind of interesting.
Yeah. Is anybody daring enough to unmute themselves and maybe throw out some possible ideas that we do with this person that's having some dizziness, falls at home? Their blood pressure readings show that they're having a little orthostasis. What are some ideas that we have out there?
This is Sarah with Guardian and Protective Services in Bismarck.
Hi, Sarah.
Hi. So I'm a licensed social worker and a national certified guardian, and I guess what I would look at first is, I'm just going to throw it out there, is their blood pressure meds. If that needs to be adjusted, maybe they've had some blood pressure problems in the past, and they need to have a review of their meds for their blood pressure.
Yeah, thanks, Sarah. I think you bring up a really good point, and I think one thing that I always do as a consultant is make sure that we have some recent blood pressures, and make sure if we don't have nursing check a few more blood pressures. We don't really need very many orthostatic blood pressures to show that we're having issues. But if we have kind of what their normal everyday blood pressure at different times, and we're able to get that to the provider, that really helps them kind of decide, yes, we need to back off. And in this case, it doesn't really say we have edema. So I guess I'd look at maybe we start tapering down on that diazide to just a half of that dose and assess, and then see if we can go off of it. Obviously, the amlodipine or Norvasc can cause edema. So if the person did have edema, I'd kind of want to know, when did that edema start occurring? Anything else on hypertension there, Doc, that we should mention?
Sorry, I was responding to the chat, so I'm not going to be able to.
No, that's right. I covered that question. So what else do we have out there for ideas on this one?
I'm wondering too, this is Melissa Kynes from the Department of Health. What time these are all being taken? Are they taking all of these medications that are BID, TID at 7 a.m.? Are they taking 20 of them? Or are they, different times of the day?
Yeah, that's another good question, and kind of can help with the assessment as well.
This is Brenda and Minot at Minot State University. I guess one of the things I'd really look at would be the alprazolam. I think that could be a big indicator as far as like the dizziness and the falls. Yeah,
we know, and we have lots of literature that shows that benzodiazepines long-term can cause a lot of problems and potential side effects. It's not going to add to our orthostasis, but I'd agree that we should start looking at tapering down on that medication. And so a couple different things that we could do. We could move that Celexa or citalopram to the morning, because sometimes SSRIs can be activating. So that might be an option too if it's causing some of the sleep issues. But I definitely, no matter what, probably increase that SSRI and see if we could taper down on that alprazolam, and then maybe hold a dose, maybe change it to PRN. But if it is long-term care, then we have to deal with every 14 days that we need to address that PRN. The other option would possibly be using something like mirtazapine instead of that Celexa, and use that for anxiety, depression, insomnia, and maybe we start tapering down on that alprazolam. And maybe I'm stealing somebody's thunder, but by decreasing the trazodone or tapering off, that's another drug that can add to orthostasis. So that's a potential option. Any issues that people see or we should be thinking about if someone actually did use timolol for glaucoma?
Well, this is Dorinda from Region 7. I was looking at maybe all these constipation meds, maybe find out if she's having some serious diarrhea with that many senna and colace and biscotta, maybe. I agree with the hypertensive and depressive med reductions, but also make sure that we're not causing a bunch of diarrhea in this patient due to all the laxatives and things that she's taken.
Yeah, their regimen is kind of a joke. We've got bisacodyl and senna, which are both stimulant laxatives, so that's kind of duplication. We have colace in senna-S, so why don't we just get rid of the whole thing, and maybe we just consolidate to senna-S, maybe 2 tabs twice a day, and then we titrate from there. And then obviously, if we're having constipation issues, we should really look for anticholinergic meds, opioids, and this person really doesn't have a lot of that, so we can't really blame it maybe on the meds too much in this case. What other ideas are we having out there?
That timolol, this is Brenda and Minot again, that timolol is a beta blocker, and that could certainly kind of potentiate like the drop in the blood pressure where she might be feeling dizzy when she's getting up.
Yep, and it's rare to happen. The sad thing is Todd Johnson, he's on this call. He's had this one come up. I had this one come up in my grandma a couple years ago where she needed multiple medications, and then they added timolol, and my mom called and and asked about her being dizzy and all these type of things. And it was after the morning, after the nurse came in each day, and I'm like, what med did they add? It was Timolol. And I said, you're kidding me. I said, Todd's told me this story for years. I didn't believe him. And we had that problem. If we're not properly administering beta blockers, if we're not occluding that lacrimal duct after administration, that medication gets absorbed, bypasses the first pass effect, and so we get a fair amount of beta blocker that can add to orthostasis. So very good one, Brenda. Thank you.
Yeah, my thoughts always when I see beta blockers, either oral or topical, is to say, whoa, okay, you've got beta blockers. How about alpha blockers? Because if you do both alpha and beta, so things like Flomax on the older male, for example, who's on not only finasteride but also Flomax, you go like, that really predisposes to orthostatic hypotension. And I believe the literature supports in that case that two together for prostatic hypertrophy, finasteride and Flomax, are not superior to one agent alone. So Flomax, as my understanding, works sooner than finasteride, but you don't get additive benefits by having both. So that to me is another opportunity for deprescribing, and usually I get rid of the Flomax.
Yeah, good example where, yeah, the finasteride takes that 6 to 12 months to kick in and reduce the size of the prostate, and then later on, yeah, see if we can back off. That does bring up a good point too, that we do a lot of work in with psychiatry, and so many times they'll be using propranolol for anxiety or beta blockers for whatever reason. Well, then all of a sudden we want to add on Minipress, or one of the one of the alpha blockers for PTSD, and we got to be really, really careful because you can cause orthostasis, and really need to titrate that slowly and really rethink, do we need both many times?
Yeah, and that's a tough one too in terms of goals of blood pressure treatment. So I keep struggling with the recent information from the SPRINT study for high blood pressure in older adults, where it shows that you actually gain 3 years of extra life expectancy if you maintain a blood pressure systolic of 120. And I'm from the school where, well, 140 to 160 systolic was pretty good, if you achieve that. Now they're telling us 120 is the target, and I just think, my goodness, how much orthostasis. And they claim that there is not that much orthostasis, and it does not increase the risk of falls by using that targeted of 120. My only caveat is that in choosing to move in that direction, to follow the SPRINT study recommendations, I tend to evaluate the patient's functional status, and if they're high functioning, if they're on 75 going, looking like they're going to live to 100, then I get more aggressive with the blood pressure management. But if they're, functionally impaired with one activity of daily living, then maybe not so much. I'll just add just a comment. Todd may know this. Rosalind, the sad news in a sense, Rosaline Kane, who was one of the founders of the Activities of Daily Living, just recently passed away as, one of the national treasures in, gerontology. Both she and her husband really pushed this whole assessment of older adults based on their functional performance. So just a side note there.
Yeah, I knew Bob had. I didn't know about Rosalie.
Yeah. Sorry for the sidetrack there, Mark.
No, that was very good commentary, because yeah, many times, and that maybe goes back to having everybody on the same page of all the providers that are following somebody is, yeah, what are our goals of that blood pressure, and do we need to push it lower or not? So yeah, very good.
Yeah, and there's a comment from Warren Looney that was to the effect of wondering what the pulse of the patient is, as a, both on systemic and topical beta blockers, as to whether there's symptomatic bradycardia. And I wonder if you could comment in addition to that about the anti-hypertensive effect of beta blockers going beyond the chronotropic effect. So once you slow the heart rate down, do you get better or additional benefit for blood pressure control by increasing the dose?
Yeah, Warren brings up a really good observation as well, and it probably goes along with getting more blood pressure checks. We also need to know what that pulse is, right, to make sure that they're not an AFib, and we can't back off on that beta blocker. But also, if we're worried about bradycardia, and I'm probably not the cardiology expert, so Dr. Jurevich, I'll maybe let you add a little bit more on the blood pressure item.
Yeah, thanks. So my understanding is that once you achieve a slower heart rate, you can still achieve further blood pressure lowering effects by increasing the dose of the beta blocker. But the impact on the older adult is not as clear, and I believe very variable. So it's not always a clear-cut thing.